Good afternoon, everybody. My name is Karla Kurrelmeyer, and I'm an echocardiographer here at the Houston Methodist Heart and Vascular Center, and I'm joined by Dr. Carlos El-Tallawi. Today, we're going to talk about the echo and MRI assessment of cardiac masses, and we're going to remind you that if you want to join by web, you can go to polleve.com, enter DeBakey, and respond to this activity, or you can also join us by text, by texting DeBakey to 37607 and text in your message if you have questions for us at the end. We'll save a little bit of time to answer those questions. So let's start off by talking about the echocardiographic assessment of cardiac masses and cardiac source of embolus. So echo, compared to the other imaging modalities, CT and MRI, does have some advantages, even though it's a very, very old technology. And one of the main advantages is it gives you dynamic, real-time evaluation of the mass. So it allows you to determine if that mass has independent motion compared to the other cardiac structures. The extent of the mass within the heart can also be determined, and the hemodynamic consequences of the mass can be determined. So you can determine whether or not it's causing valvular regurgitation or valvular stenosis or compression of the chambers, for example. Predisposing conditions can also be identified, such as an apical aneurysm leading to a low flow state, which causes that thrombus to occur, or rheumatic valvular disease, which predisposed to endocarditis, for example. It has disadvantages compared to the other imaging modalities too. And the biggest disadvantage is suboptimal image quality in 10 to 15% of cases, resulting in either going on to other imaging modalities if you know that the mass is there or suspect that it's there, or more invasive measures such as a TEE, or missing the mass altogether. It has a very narrow field of view, so the extra cardiac manifestations of the mass are not delineated. For example, if the mass is coming from the lungs, a tumor that's metastatic to the heart, you cannot see the tumor within the mass like the other imaging modalities can. And there's a possibility of mistaking an ultrasound artifact, because there are many artifacts using echocardiography for a mass, leading to unnecessary testing, and it cannot provide data on the tissue characteristics of the mass. It cannot tell you whether or not it's predominantly fat, predominantly calcification, fibrous, or thrombus like CT or MRI can. So the most important part of the echocardiographic assessment of a cardiac mass is to try and determine whether or not it's a normal variant, an artifact, or it truly is an abnormal cardiac mass. And in order to do that, you really need to know the normal structures and variants that may simulate a cardiac mass in the various chambers and valves. In the left atrium, you need to be aware that the raphe between the left upper pulmonary vein and the left atrial appendage, which is sometimes called the warfarin ridge, the Coumadin ridge, or the Q-tip, can be unnecessarily large, so that you can actually see that on transthoracic and may think it's a mass, an abnormal cardiac mass. The atrial suture line after cardiac transplant can be particularly prominent, plus there can be artifacts secondary to prosthetic valves, both in the aortic position or the mitral position, or there can be significant mitral annular calcification or calcification of the aortic valve. In the right atrium, the crista terminalis can be especially prominent and may simulate a mass. The Chiari network and eustachian valve can also be prominent and calcified, which may make you think it's a mass, an abnormal cardiac mass. There can be lipomatous hypertrophy of the interatrial septum or the RA free wall. And of course, pacemaker wires and catheters can have lots of artifact associated with them, so you may think that they're abnormal masses. And the atrial suture line if it's a biatrial cardiac transplant. And the LV, the papillary muscles, they can be aberrant, or you can have accessory papillary muscles. And usually there are chordae associated with them, and these can be mistaken for masses. Also, there are LV tendons. Specifically, if they're calcified, you may think it's an abnormal cardiac mass. And the RV, the moderator band, can be especially prominent in people with lung disease, pulmonary hypertension specifically, and it can become calcified. Papillary muscles can be accessory or in abnormal locations. And again, this is where pacemaker wires and catheters live, and they can have artifacts associated with them. So basically, how can you tell if it's a normal variant, an artifact, or an abnormal cardiac mass? For artifacts, it's easy. If the mass is in the same location in multiple different views, it is some sort of mass. You just don't know if it's a normal variant or abnormal. Artifact, you're only going to see it in one particular view. If the abnormal structure is located in the posterior chambers like the left atrial appendage, the left atrium, the aorta, the mitral valve, the TEE is excellent for visualizing those structures. And contrast can be very, very helpful because artifacts will disappear with contrast. A true cardiac mass will not. And integrating the echo and clinical data is also particularly important when trying to determine if this is an abnormal cardiac mass. So this is an example. You can see that it's pretty obvious where the mass is. It's a very circular mass in that posterior annulus on that peristernal long axis view, and you also see it in the posterior lateral annulus on the short axis view. And in the apical views, you can see that it's sitting there in the lateral annulus. It's very bright, very calcified, very circular, and it doesn't, by color Doppler, doesn't appear to be causing any sort of hemodynamic consequences. This is an excellent example of caseous calcification of the posterior lateral mitral annulus. In this particular case, you can see that there's a very linear structure attached to the intraatrial septum in the transthoracic views. In the transesophageal views, which are on the bottom, again, you can see a couple abnormal structures. There's one very displaced in the apex, and there's one right next to the mitral valve, and you can see a linear structure attaching those. This is a classic example of an accessory papillary muscle with accessory chordae attaching the two aberrant papillary muscles. So this is a woman who presented with atypical chest pain and got an echo just for that reason. And you can see that she has a very mobile mass there in the right atrium, and you can see the intraatrial septum is also very mobile. So this is a very classic example of a eustachian valve and an atrial septal aneurysm, both normal variants. So once you've decided that it's no longer a normal variant and it's not an artifact, how can you use echo to determine whether or not it's a thrombus, a tumor, or a vegetation? Well, there's four things that are very important. The first is location, because thrombus and vegetations, they live in certain locations within the heart. The thrombus is always going to be found in the left atrial appendage, the LV apex, or it's going to be in the IVC, RA, or RV if it's in transit. The tumor, it can be anywhere in the heart on any cardiac structure. The vegetations predominantly occur on valves. The appearance can help you because thrombi are always very pedunculated or spherical, or they can be layered if they're mural thrombi associated with regional wall abnormalities. A tumor appearance will vary. A vegetation is always very irregular, highly mobile, and on the low flow side. The associated findings for a thrombus, you're looking for regional wall motion abnormalities and LV dysfunction. So for thrombi, you're always looking for a reason for a low flow state to allow that thrombus to form in the first place. So if it's in the left atrium, you're looking for mitral stenosis or atrial fibrillation. For a thrombus in transit, you're looking to see whether or not there's RV dysfunction, telling you that it's already made its way to the lungs and resulting in significant pulmonary hypertension and subsequently RV dysfunction. A tumor, you're looking for invasion, obstruction, and collapse. And of course, for vegetations, you're looking for valvular regurgitation. And the clinical history will be very, very important in allowing you to put all of these pieces together to try and determine exactly which one of the three it is. So this is an example of a 48-year-old man with syncope, and you can see that there's a very large homogeneous structure in the left atrium, and it looks like it's attached to the posterior wall of the left atrium by a very thin stalk. This is a very classic example, except for the stalk. Usually the stalk is attached to the intraatrial septum, but otherwise the appearance is very classic for a myxoma, which is the most common primary cardiac tumor in adults. So this is a 60-year-old woman who presented with shortness of breath. She had 2 echoes, 2 days apart. And basically in the first echo on the left-hand panel, you can see that there's a very circular thrombus, which is in the IVC. And then a couple days later, that thrombus has now reached its way into the right atrium, threatening to get across the tricuspid valve and into the right ventricle. So this is a classic example of a thrombus in transit. So this is a 21-year-old patient of mine that I actually had a chance to take care of. And she presented with dyspnea, fever, and chills, and was found to have multiple pulmonary emboli. And the echo held the key to why she had all those pulmonary emboli. You can see that in the upper right-hand panel, the zoomed peristernal long axis view, there's a very mobile mass attached to the interventricular septum there. And you can see in the bottom left-hand panel that it's a very irregular flag-shaped mass that's reaching all the way to the pulmonic valve. And then finally, in the bottom right-hand panel, you can see why that mass is there. You see a little translucent area there in the interventricular septum. So this is a vegetation, which is on the low flow side of a membranous ventricular septal defect. And that low flow side is the right ventricular side. And the reason that this is here is she subsequently confessed to IV drug abuse. So this is a 19-year-old woman who presented with lupus and lupus cerebritis. She had altered mental status. And you can see, it's slow in moving here, but you can see that the mitral leaflets are very thickened all the way down from the tips to the base. And both leaflets are equally involved. So this is a classic case of valvulitis or Lehmann-Sachs endocarditis. And this was an interesting case. This was a 74-year-old man who had a history of CAB and came for an elective PCI to the distal left main and proximal circ, and several hours earlier, and he had this echo because he had cardiac arrest and had a impella placed, because you can see that impella there in the LV, and a stat echo. And basically you can see that there's this huge mass lateral to the LV. And then on the peristernal long axis view below, you can see it's very circular. So it's a very oblong circular mass, and you can see it's causing compression of the myocardium itself. When it's causing compression like that, it's telling you that it's not in the pericardial space, it's in the intramyocardial space. So this is a very rare complication. It can be spontaneous with STEMIs. And it is intramyocardial, or sometimes called a subepicardial hematoma. So is there a role for echo contrast? Well, you can see from this picture, it's very technically difficult. You can't really see the apex. It's kind of hazy up there. The EF looks like it's down. You've got a suggestion that there's regional wall motion abnormalities in the apex, possibly an apical aneurysm, and your suspicion for a layered mural thrombus is pretty high in this case, just based on what you're seeing. And here you can see contrast was given, and actually there isn't even an apical aneurysm. It's just global hypokinesis of this ventricle, and there's absolutely no thrombus present. So absolutely, yes, there is a role for echo contrast in trying to determine whether or not a mass is present. Here's another echo, again, technically difficult in the same area. You can't really see the apex, it's kind of locked in. The LV size looks normal, the LV function looks pretty normal. You don't have a hint of any sort of regional wall motion abnormalities, but based on the contrast guidelines, you know that when this much of the endocardium is not visualized, that you need to give echo contrast. And when echo contrast was given, you can see that there's a little bit of an apical aneurysm up there, and there is a very pedunculated thrombus that's in that very small apical aneurysm. So tumors, I know Carlos is going to touch on this, so I'm just going to briefly go through this. They're usually metastatic. 95% of all cardiac tumors are metastatic, and usually they come from within the chest themselves, with lung being the number one. Metastatic tumors will involve the pericardium 75% of the time. The primary cardiac tumors are usually benign 75% of the time, so the rule of 75s. And the most common one we already touched upon is a myxoma. And the most common malignant primary cardiac tumors also frequently involve the pericardium, just like metastatic tumors. And they are always your sarcomas, with angiosarcoma being the most frequent. So this is a 44-year-old man who presented with dyspnea. And on this transthoracic echo, you can see that the LV is fine. You can see the RV is enlarged, and you can see that the RV function is depressed, and you can see that there's a homogeneous mass located in the RV. On the short axis one in the upper right-hand corner, you can see that there's a small pericardial effusion all the way around the heart. So you're already thinking this is either metastatic or a primary malignant cardiac tumor. On the bottom left-hand panel, you can see that it's perfusing, which also helps you to know that this isn't thrombus. There's blood vessels in there, so this is definitely a tumor. And again, on the bottom right-hand corner, you can see the pericardial effusion, and you can see the regional wall motion abnormalities caused by this tumor because it's invading into the myocardium of the right ventricle. So this is a classic example of an angiosarcoma. So this is a 35-year-old woman who was referred because she had dyspnea, and she was found to have a mass in her heart. And basically you can see on this TE, a lot of the twirling is to show you that this mass is in the pulmonary veins. So it's filling up those left upper pulmonary veins and also that left lower pulmonary vein on the bottom left-hand side. So this is telling you that it's likely coming from the lung because it basically likely is a local metastasis from the lungs because it came via the venous route through the pulmonary veins. But again, this is showing you the inferiority of echo. This person definitely would need further imaging to try and determine the source. And this was a sarcoma with local metastasis from the lung. So the myxomas, we talked about the classic presentation of myxomas, but you will see atypical presentations of cardiac myxomas not uncommonly because they are basically 27% of all primary cardiac tumors are myxomas. And you can see most commonly they are supposed to involve the left atrium, but these are examples of atypical presentation where you see there's one in the upper left-hand panel in the right atrium. There's also one over there in the LV, and the path down below the surgical specimen where it's being removed is shown there down in the bottom right-hand corner. And it can be multiple in familial syndromes such as NAME and LAM. So again, if it's got this classic homogeneous appearance, you know, odds are it likely is going to be a myxoma, but again, path is always the issue, or further tissue characterization with MRI. Okay, so this is another atypical presentation where a young woman with Behçet's presented with dyspnea, and she was found to have very thick RV chordae, and you can see on the contrast enhanced images, especially the one down below, you can see how thick it is, and it really did look like it was some sort of pathologic mass. So she underwent surgical removal of this and reconstruction of all those chordae in the RV. And this was subsequently determined just to be inflammatory infiltrate, and she had a recurrence post-op on those artificial chordae. So I think this is our last atypical presentation. Again, this was a 50-year-old woman who just got an echo for hypertension. You can see that the heart, based on these views, looks pretty normal. She did get contrast though because the apex was not well visualized in these views. And you can see that there's a very mobile mass seen there at the apex. And the question is, what is this mass? Because again, the apex is moving quite well. So you would not think that this is a thrombus. You're thinking that this is more likely some sort of tumor. So she basically subsequently underwent surgical removal of this, again, because it was a very atypical presentation, and the clinical scenario did not help us. Further imaging did not help us in this particular case. And you can see these are the intra-op views where he's literally now inside the heart, inside the left ventricle. You see all the trabeculation there, and basically you're going to see the mass in just a few more seconds. And you can see it's hiding there behind that trabeculae. It's a very mucoid, yellow-looking sort of mass, and it looks like it's very tightly adherent and hidden behind all the trabeculations in the apex. And the rest of this video is literally just trying, the surgeon is cutting through all this trabeculae to like actually extract this mass from the LV apex. And there it is. So it's going to pop out in just a second. So this mass was sent on to pathology because, again, it was a very, very unusual location for this. And this turned out to be a papillary fibroelastoma. So these usually occur on the high flow side of valves, sometimes chordae. Very unusual for it to be stuck to the trabeculae, like in this particular case. And that was the reason for the removal. There is some sort of concern about embolization with papillary fibroelastomas, but you could see that this one was very tightly adherent, so the likelihood of that would have been extremely low. So what is the role for echocardiography after stroke, so in cardiac source of embolus? Well, the role is to identify whether or not an intracardiac mass is present, such as a thrombus, a tumor, or vegetation that may have partially embolized, so that there may be a part of it still left when you do TEE. To identify an abnormality that may predispose the patient to development of an intracardiac thrombi, such as mitral stenosis, left atrial enlargement. You're looking for contrast, spontaneous contrast echo consistent with flow stasis, LV aneurysms, and you're also looking for aortic atheroma. Or to identify a cardiac anomaly that may serve as a potential source for systemic embolization, such as a PFO, an atrial septal defect, or a Lambeau's excrescence. However, a definite cardiac source is only found in about 15 to 40% of ischemic strokes, depending on the series that you look at. So this is a lady who presented with a facial droop and left arm weakness. And you can see that there's a mass in there, and it's in the left atrium, and it's moving around, and it's threatening to get across the mitral valve. And because she had already had a stroke, it was decided to go in and take out this mass. You can see the left atrium's humongous in this case. The LV function's not very good. And the patient was in atrial fibrillation. She was just a setup for this thrombus, and this was a thrombus in transit threatening to be another stroke. So this is looking at this is looking at the thoracic aorta following the stroke, because frequently we're looking for ulcerated plaques or plaques that have highly mobile components that may have either embolized as with respect to an ulcerated plaque or threatening to embolize. And this is just showing you an example in the right-hand panel of an ulcerated plaque, which may have been the cause of this particular person's ischemic stroke. Here's an example again of an early thrombus formation in the left atrial appendage of a patient with atrial fibrillation. And again, in a stroke patient, this would be enough evidence that this likely could be the etiology of the stroke, and this patient would be treated appropriately with anticoagulants. And of course, this is always part of the TE exam, looking for atrial septal defects or patent foraminal valley, which may have, and spontaneous shunting, which may have led to the embolic stroke. And this is just a classic example of somebody with an intraatrial septal aneurysm, which increases your likelihood of having a patent foraminal valley. And you can see that there's a small amount of contrast that spontaneously crosses across that slit-like patent foraminal valley in the intraatrial septum. So this was a patient that we took care of that actually presented with a pulmonary embolus and a stroke. Very, very rare, but you can see why he had these two conditions. You can see that on these 3D images and on that still frame 2D image, there is a thrombus stuck within the patent foraminal valley. So half of it is on the right atrial side, half of it is on the left atrial side. And this was a very atypical presentation of a woman with lupus and a stroke. And you can see that she has a very mobile mass attached to the mitral leaflets. Go on. because this is her TE following a stroke. You can see that she also has a very homogeneous mass attached to the interatrial septum and within the left atrium itself. And you can see also that she has a lot of mobile atheroma and also ulcerated plaques within the ascending aorta. So she had multiple etiologies for a stroke, and it was subsequently determined that she had antiphospholipid antibody syndrome, and all of these masses which were removed were actually just thrombi. And so she was, basically the treatment for her would just be anticoagulation. So if you look at the ASC guidelines for the use of echocardiography and the evaluation of a cardiac source of embolus, you can see this is the appropriate criteria. And literally, we're running out of time, and I want to save enough time for Carlos. But literally what it says is it's pretty much appropriate in every single patient. So yes, we do a lot of TEs for patients following stroke looking for cardiac source of embolus, and this is why. So thank you very much. I'm going to pass the baton over to Dr. El-Tallawi.
Thank you so much, Dr. Kurrelmeyer. So that was a beautiful lecture, and I don't know if you agree, but I think Dr. Kurrelmeyer made a good case as to why sometimes we need more advanced imaging to define a mass and assess its constitution essentially. So I'm going to talk about cardiac MRI. I have no disclosures for this talk. So first of all, when we look at a mass on echo, obviously it's always, most of the time, vast majority, we start with an echo. So what is the differential diagnosis of a cardiac mass whenever we see it on echo? It's usually, as Dr. Kurrelmeyer pointed at on multiple occasions, it could be an artifact, it could be a normal variant, meaning it is there, but it is not truly a pathologic finding. It could be a thrombus, it could be a vegetation, or it could be a tumor. And then within a tumor also we have either benign or malignant, which also I'm going to talk about. So what is the difference between echo and MRI? So again, these are some of the advantages and disadvantages of echo that also Dr. Kurrelmeyer mentioned. Essentially, the advantages is that it is readily available and portable. We can usually know the mass location and morphology, and we have the beauty of Doppler, which is very particular to echo, where we can see if there's any altered hemodynamics from the mass, such as valve damage. So we use usually all this information, and in using deductive reasoning, we can usually get some sort of a differential diagnosis. However, we cannot truly always define what the mass is. The disadvantages of echo is that obviously it is operator dependent and it's limited by the acoustic windows. It has a limited field of view, very narrow, very usually small depth of field. So we cannot really see the tumor extension or the mass extension and the involvement of other structures, and obviously we cannot do tissue characterization. If TEE is needed, we have to always think that TEE is semi-invasive and it has its own set of contraindications. For MRI, we have usually all these characteristics of echo are available, except maybe the portability and the Doppler, but we can see the anatomy, the morphology, the size, the location, the mass extension, its vascularity. Most importantly, its tissue content. Is it fat? Is it thrombus? Is it fluid? So we can put all of these together, and the mass location and its relationship with the other structures. Importantly, we can plan the therapy because of the imaging. We can tell the surgeon where the mass is. They can get a good idea how to approach it, and also importantly, we can use it to monitor response to therapy of the mass. This is just a table that kind of summarizes the differences between echo and MRI. Again, the advantage of MRI is the wide field of view and tissue characterization and perfusion assessment. When it comes to temporary resolution, obviously echo is much better than MRI, and this plays a role in characterization of smaller masses, such as small, very mobile vegetations, for example, or a Chiari network. These kind of structures are not well seen on MRI. MRI likes to see bigger masses that are not as mobile. Spatial resolution is very decent on MRI. So that also helps us a lot in characterization of the mass. So how do we protocol a study in order to assess a cardiac mass? So usually most of the time, a patient comes to the MRI lab, or they already had an echo, and they know there is something there. They know it's a mass. They're not sure if it's pseudo-mass or a mass. So we need to apply a certain protocol to characterize this. So the protocol is usually divided into an anatomic assessment and a tissue characterization part. For the anatomic assessment, we do all the standard cuts, axial, coronal, sagittal stacks. We also do cine imaging using the standard planes that we know from echo, 3, 4, 2-chamber views. But also we have the ability to choose new planes that are targeted specifically at the mass, unconventional planes, I should say. For tissue characterization, it is usually divided into 4 parts. We have the T1, T2, and T2 star imaging, which will give us an idea as to the content of the mass. This is pre-contrast, and then we give contrast, and then using contrast we can guess 3 types, get 3 information. Essentially, we can look at the first pass perfusion, essentially assessing the vascularity of the mass. And then when we wait for 5 to 10 minutes or so and we image again, we can check for late gadolinium enhancement. Does the mass retain the contrast? And also we have something we call long inversion time imaging. And this is specifically used for thrombus imaging. And this is a very powerful tool used in MRI. So for the anatomic assessment, obviously, as I said, these are a set of images where how we can look at the mass in different views and assess it in different ways. And we have also the targeted non-standard images. So we will get through this anatomic imaging the mass location, morphology, assess its mobility, its physiological impact, and also its extension. Using the tissue characterization portion, on the left side, using pre-contrast, we have the T1 weight sequences. Usually fat or acute thrombus have high signal on T1 imaging. On T2, it's more for edema or water content. And then we have the T2 star, which we use usually for assess if there's any iron overload. Next, whenever we administer the contrast, we assess at the beginning, whenever contrast is first injected, the first pass perfusion to assess vascularity. This is followed by the delayed hyperenhancement to assess for fibrosis or necrosis or inflammation. And then at the end of the study, usually we do the long inversion time imaging to assess for the presence of a thrombus. So this is, we'll go through a tree algorithm, if you will, into stepwise cardiac mass evaluation. First of all, number one thing, is it a true mass or is it a pseudo mass or a normal variant? This is just a quick table that, about what kind of structures can be mistaken for an abnormal cardiac mass. Dr. Kurrelmeyer showed many of those examples, but just to give a few examples, the eustachian valve, Chiari network, lipomatous hypertrophy of the interatrial septum, pectinate muscles in the left atrial appendage, lumbal's excrescence, just to name a few. There are a lot of structures on echo that can be missed and thought of as being abnormal or pathologic masses. I'm going to give a few examples of those. So this is a case of a 74-year-old male who was found to have an incidental mass in the right atrium. You can see on echo, you can see this mass in the right atrium over here. Obviously you can't really tell. This is very unusual. We do a lot of echoes. We don't see this every day. So what this could be. Obviously, again, with the powerful imaging of MRI and the wide field of view and the tissue characterization, you can and also the ability to relate it to other structures, you can clearly tell that this is a prominent crista terminalis. Another mass seen here for a 73-year-old female admitted with epigastric pain. You can see there's something lying behind the left atrium. Whenever you see something on echo like this, you have to think of 2 main differential diagnoses. One is pretty serious and one is less so. So this usually could be either an aneurysm in the descending aorta, where the aorta usually goes behind the left atrium in the thorax, or this could be a hiatal hernia. These are usually the 2 main ones. Now, if you pick this up during acquisition and you want to save the patient another study, you can usually give them carbonated soda while imaging, and then if you see bubbles going in that structure, you can know that this is a hiatal hernia. In this case, the patient had a cardiac MRI, and you can tell that this is truly a hiatal hernia going through the diaphragm right behind the left atrium and showing on echo. Again, this is the power of the wide field of view of MRI that will help us make this diagnosis. CT would have given us the same information. After we establish that this is a true mass, that's not a normal variant or a pseudo mass, we need to assess, is this a tumor, or is this some other type of quote unquote benign structure? So let's go through a few cases. This is you can see on the echo here that you have something in between the right and left atrium. You have this like thick high signal coming from the septum, and you can tell clearly on the, you already get on echo, you have an idea already what this is, and then you have the MRI there, which is showing also more clearly that structure. Nicely below, you can see on the T1 and T2 how you have the very high signal, very bright signal on T1. As we said, T1 is, will give a high signal when you have fat. You can see here the epicardial fat and in the chest wall that has the same signal, meaning this confirms also that this is fat. And then on the right side we have T2 imaging with fat saturation, and you see how it turns black. So this is clearly a case of lipomatous hypertrophy of the interatrial septum. I just added one more slide here. I want to talk one thing about this entity, which I think it's important, and people usually don't think about it, but the interatrial septum, lipomatous hypertrophy of the interatrial septum is not an intracardiac mass or structure. It is extracardiac. It is located in the groove that is between the left and right atrium, usually posteriorly. It's called the Waterston groove. And usually when we acquire the imaging on echo, again, because we have this narrow field of view, we cannot truly assess that. But red blood cells essentially do not interact with the fat that is in the interatrial septum. This is outside the heart. This is another structure. Is it tumor or a pseudo-tumor? Again, on the first upper left, we have Actinic imaging. We have this like round, well-circumscribed structure over there. T1 on the panel B, dark. Panel C is T2, bright. Again, T2 means edema, means fluid. And then late gadolinium enhancement on panel D, you have 0, none. So this, we can guess from this immediately, based on this imaging and based on the location, which is at the RA-RV junction, that it is most likely a pericardial cyst. One more case we have here that of a 77-year-old female referred for surgical removal of a mass in the left atrium found on TTE. And you can see immediately here on the short axis view that you have something, a thick part of the muscle over here. Same on the 4-chamber view, something in the base of the LV and extending into the LA. This is very unusual. We'll apply the tissue characterization imaging. T1, no signal, or usually when we say like low or normal signal or low or high is compared to the myocardium. So you can see the myocardium here is grayish. This is dark. Same with T2. First pass perfusion is dark, and then on LGE you have only this like rim around the mass of contrast retained gadolinium, but like the center is dark. This is usually typical of caseous necrosis, mitral annular caseous necrosis. And usually this structure is surrounded by fibrous tissue. That's why you have LGE in that area. It's not all pure calcium. And it was confirmed on a CT, also showing this dense calcification in that area. Here, that's no longer a pseudo-tumor versus a tumor. This is here, the question is this a thrombus versus a tumor? We have this case of a 52-year-old male with diabetes. They had a mitral valve repair. They are in atrial fibrillation, and they were admitted with heart failure. You can immediately tell that there are floating masses in the right atrium on the 4-chamber view and on this RV-focused view. The question is, yes, you can guess from AFib and the history that these could be clots, but this is very unusual. Can you be sure? Usually not, like assuming this is echo. So if you apply tissue characterization, you see some slightly high signal during on T1 on the left and also on T2. And if you look at the first pass perfusion no contrast shows up, in these masses. Usually, we'll go back to that, but like when we, consider this, or think of this could be a thrombus, this is where the power of the long inversion time imaging is. And this usually long inversion time, meaning we flip the protons and then we wait for like approximately 600 milliseconds before we apply the imaging. Usually clots, the signal from the clot is nulled, or it's zero at the 600 milliseconds mark. So, and this you can see here how it's completely dark. There's no signal coming from that structure, confirming that this is a clot. Now, going back here, usually chronic thrombi have no signal or low signal on T1 or T2. However, if the thrombus is acute, you can have this, it could have some edema or some fluid within it. So it could have some higher signal on T1, on T2, and T2, such as in this case. So this is one thing I wanted to mention, that depending on the chronicity, T1 and T2 for a clot can be different. I think this is the last case here for this part of the algorithm. At least we can see here on the fourth chamber that we have a mass in the left ventricle. Again, could this be a clot? Could this be a mass? We can look at the T1 and T2 below, and you can see the high signal coming from that mass. So this is truly a high signal, being unusual for this being a clot. And you can also tell on the CNA imaging that you have a little bit of high signal, heterogeneous signal coming from the mass. You have like white center and you have darker rim. Also unusual for a clot. On first pass perfusion, you can see that a lot of the mass, a big portion of it, does get perfused. So this tells us that there is a vascularity in there. So this goes against a clot. So in this case, it turned out to be a cardiac metastasis. One more case here, I just like to show because we don't see much of those very often. You can tell probably immediately from looking at the CNA imaging as to what this could be. You have this like mold of, something sitting in the mid to apical portion of the ventricle, and the walls of the LV in the apex have maintained thickness. So this argues against possibly like scar or a kinesis in that area, favoring just a regular clot. And you can tell on the LG on the right side how you have this rim of white around a center, a dark center. And this is characteristic of the fibrothrombotic nature of Loeffler's endocarditis. Thrombus. It's important to mention a few words about thrombus because a lot of times, patients get MRIs just to rule out or rule in a thrombus that was suspected on echo. There are many ways we can, information we can put together to diagnose a thrombus. However, as I mentioned earlier, the long inversion time imaging is the most powerful and has, on multiple studies, it showed the highest accuracy at identifying a thrombus. In this particular one, it has 95% accuracy compared to other parameters. Compared to echo, because specifically of this imaging technique, the specificity for MRI and echo is high for thrombus. Whenever you see something on echo that's, in an akinetic wall in the right location and you see it, you are sure most of the time that this is a thrombus. So it is specific. However, there are certain areas where you might miss it or you might not see it. That's why echo takes a hit in terms of sensitivity. However, because of MRI, again, the imaging quality and the field of view and this long inversion time imaging, the specificity is usually higher than echo. This other study, they compared echo with contrast echo with MRI, and with contrast echo, it almost doubles the sensitivity of echo in terms of identifying thrombus. Again, because you turn on the lights inside the chamber, so you can see if there's any thrombus hiding in there, like Dr. Kurrelmeyer showed a few of those cases. But it's not as high as cardiac MRI. And the reason why echo can miss thrombi are usually two main reasons: if the thrombus is small, and more importantly, if it is layered or mural. So these are the types of thrombi that are missed by echo, because especially when you give contrast, the contrast illuminates the cavity, the wall, the myocardium becomes dark. So if you have a mural thrombus sitting there, you might not be able to identify it. On MRI, you will still be getting two different signals from the myocardium and the thrombus. So therefore, it is more powerful at identifying a mural clot. Okay, now let's say we did first pass perfusion and we have contrast uptake, whether on first pass perfusion or an LGE. So now we know that this is probably a tumor. It's no longer a thrombus. This is such a case, for example, here. You can tell on the left side how on first pass perfusion you have contrast uptake inside that mass, and also on LGE, in comparison to the right side where you have an apical mass that did not have any first pass perfusion and no LGE, indicating that this is a clot. How do they compare? What do we use in order to differentiate between thrombus and tumor? Usually, if we have T2 signal, if we have first pass perfusion, if we have positive LGE, these are very strong parameters, especially if they're put together at favoring a tumor. However, if we have long inversion time imaging showing zero signal, this is very high accuracy for thrombus, 94% versus you see it in 2% of thrombi. Of tumors, sorry. Now, in terms of identifying the types of tumors, also MRI is powerful in that sense as well. So cardiac tumors are divided into between primary and secondary. Fortunately, primary are the most common, 75% of the cases. The myxoma being the most common. 25% of the primary are malignant, and angiosarcoma being the most common by far. However, if you want to compare primary and secondary tumors are much more common than primary cardiac tumors. Originating usually from the lungs, from the breast, from melanomas, and usually they come to the heart either by direct extension, by hematogenous spread, or through the lymphatics. Why is it important to know all this? Because location does help with the etiology. So again, we're doing the imaging, whether echo and MRI, and putting everything together. So tissue characterization and all of the things do not always give us the final answer. It's important to look at the location as well. So for example, if I have a globular mass sitting in the left atrium attaching to the intraatrial septum, this helps me a lot by figuring out that this is a myxoma. If I have structure extending into the pericardium, I know this is most likely an invasion, and this is probably a malignant, either metastatic mass or a malignant primary cardiac tumor. If I have a mass sitting on the valve, I know this is likely a fibroelastoma or a vegetation. So knowing the location is very important though. What are the characteristics on MRI of a malignant cardiac mass? Obviously, if it is large, especially if more than 5 centimeters, if it has irregular, ill-defined borders, if you have direct invasion of the tissue planes, you can see on the right side how this mass in the right atrium is going through the wall, and also you have this pericardial effusion. And it has this irregular border. So it has many features suggestive of a malignant etiology. Obviously, being also on the right side of the heart, because this is how tumors metastasize through the venous system, and obviously pericardial and pleural involvement. And if you have multiple lesions, usually this is more common in metastasis. This is a nice diagram here from a publication by Dr. Kasi. Benign tumors are usually smaller, well circumscribed. We have less or no first pass perfusion, and same for LGE, and there's usually no pericardial effusion. On the flip side, malignant tumors are usually larger, they are invasive, they have increased first pass perfusion, meaning they have increased vascularity, they have increased LGE for the same reason, and there's usually pericardial effusions associated with them. This is a table. I'm not going to go through it. This is from by Dr. Shah, published in the DeBakey journal. Essentially, the characteristics of tumor on MRI, how we can use T1, T2, and the contrast in order to identify a tumor. Obviously, that's never enough. You have to put everything together in addition to this table to try to figure out what the mass is. very frequently more than one test may be required. So MRI, yes, it is very powerful, but like it has its own contraindications, obviously. So if you have someone who is claustrophobic or someone who has a metal, maybe you want to go with CT. If you want to get coronary information at the same time because you're planning surgery, coronary CT. If you have, as I mentioned earlier, a small, highly mobile mass, TEE might be better because of the better temporal resolution. If you have suspected calcifications, CT might be better in this case. So we have to put everything together, the clinical history, signs and symptoms, sometimes the biochemical and tumor markers, and the results of the imaging in order to make the diagnosis. So my last slide here and the take-home points, that CMR has very high sensitivity and specificity for identifying cardiac masses and pseudomasses, and it gives us usually a very narrow differential diagnosis, if not making the diagnosis based on the integration of all the factors I mentioned earlier. But sometimes you will have to do, especially if you're planning for surgical intervention, a tissue biopsy might be needed in order to establish the diagnosis and plan the treatment accordingly. Thank you very much.
Okay, are we going to answer questions? Yes. Okay, so there's one question there. Are there exceptions with locations? And I think in my talk, I tried to show you the atypical locations or atypical presentations is what I called them. But an excellent example of an atypical location was the Papillary Fibroelastoma that we saw attached to the tubercle and the LV apex. That was a classic example of an atypical location. For the myxomas, they usually occur in the left atrium. So I showed you examples of where myxomas can occur in the right atrium, they can occur in the LV, RV, or there can be multiple. So absolutely there are exceptions to locations, but we do use that though to narrow the differential when we're trying to figure out what the next steps are in the evaluation of that cardiac mass. Dr. El-Tallawi, do you have any comments on that?
No, I agree completely with you. There are always exceptions to every rule, including the location of the masses. So yes, definitely. And when you face such a case, this is when maybe advanced imaging or tissue diagnosis could be important. Whenever you have this unusual kind of location for a suspected mass. I don't think we have any more questions. Thank you very much. Thank you, Dr. Kurrelmeyer.
Thank you.